Hello everybody and welcome to this lecture on the Normocytic Anemias. As always, the basics of anemia, which is defined as a deficiency of red blood cells or hemoglobin. The definition allows for both of those. And here on the right is a chart that has general guidelines for what the actual thresholds are. Notice that they're different for men and women. And of course different for RBCs and hemoglobin, but also just check with your lab, or if you're taking the test, just use the test thresholds because they can differ slightly. General symptoms of anemia: early on you'll have some fatigue, dizziness, lightheadedness. These are pretty common. As it gets a little more serious, you'll start to see it in the skin in the form of pallor, and then even more serious from there, you'll actually start to get shortness of breath because of that decreased capability of carrying oxygen. So the first step in any anemia diagnosis and differential is using the MCV, otherwise known as the mean corpuscular volume, which is exactly what it sounds. It's the size of the RBC corpuscle. I just remember that normal MCV is 80 to 100, and this is in femtoliters, by the way. 80 to 100 is normal, so obviously less than 80 would be small, aka microcytic, and over 100 would be big, aka macrocytic. This is an image of microcytic anemia. You can tell because of the generally essential pallor, because microcytic you'll usually have what's called hypochromasia as well, which is increased pallor. So this is a chart that's taken directly from Up to Date. It's a very good chart in how to diagnose anemias using the MCV method. And so normocytic anemias is the topic of this video, so we'll be focusing right here in the middle, MCV of 80 to 100 femtoliters, and this is the box of your differential, so we'll be going over this in this video. So the first step, I think, that's the most helpful for me at least in diagnosing a normocytic anemia is first deciding, is this a hemolytic or a non-hemolytic anemia? Hemolytic obviously referring to hemolysis, or the RBC breaking open, shearing. And you have a lot of symptoms, such as you're going to see jaundice in these people because they're spilling out heme, and they're getting into heme degradation and bilirubin building up in the skin, and you're going to see jaundice. That's one of the telltale signs. However, there's also a bunch of laboratory assessments you can do. The first is, how about the reticulocyte count? Reticulocytes are immature red blood cells, so they're elevated when there's an increased need to produce more RBCs. Now, in the case of a hemolytic anemia, your bone marrow is fine, so your bone marrow can make RBCs. The issue is that the RBCs are just being destroyed. So the reticulocyte count would actually be elevated in many hemolytic anemias because the bone marrow is trying to replenish all those RBCs that are being destroyed via hemolysis. Haptoglobin is a great test for this. Haptoglobin is a molecule that binds to free hemoglobin. Therefore, in a hemolytic anemia, a haptoglobin would be low because all of it is taken up and bound to hemoglobin. And so your laboratory test for free haptoglobin will be low. Bilirubin, of course, will be high. Can be direct or indirect. LDH, which is your lactate dehydrogenase, is elevated in the hemolytic anemia generally because it's an intracellular enzyme that spills out. And then if you're assessing for the possibility of hemolytic anemia, always get a peripheral blood smear. This is something that people honestly seem to overlook a lot. There's a lot you can learn by just looking at the actual blood under the microscope. And the big thing with hemolytic anemia is a lot of times you'll see schistocytes on the PBS. Schistocyte is essentially a hemolyzed RBC. So in this PBS that I have here, you can see one here, and here, and here. These are all schistocytes. And if you ever want to impress your pathology or hematology professors or preceptors, the official definition of a schistocyte is an RBC with two sharp ends and no central pallor. So let's briefly go over the kinds of non-hemolytic anemias, and the biggest non-hemolytic normocytic anemias, of course, and the biggest culprits here are going to be your iron deficiency and your chronic disease, which are the most common causes of anemia in general. Now, these usually are thought of as microcytic, and many times they are. However, early on in these disease processes, iron deficiency anemia and anemia of chronic disease are often normocytic. Why is this? Well, initially, when you're becoming deficient in your free iron, your serum iron, your body can pull from the storage irons that you have to kind of keep up with it. Therefore, you're still normocytic. But after you start to run low on even storage forms, at least in iron deficiency cases, you'll become microcytic. This is, of course, different for anemia of chronic disease because there the problem is that you can't get the storage forms out. After you've eliminated those, and you can just use the iron studies to diagnose those, and I have a video on iron studies and iron deficiency anemia. You can check that out for more info there. But after you've eliminated those from the differential, think of it in the sense that you're either producing less RBCs or hemoglobin, or you're losing it somehow, okay? And so the first thing that's usually the easiest to cross off the list is acute blood loss anemia. Now, obviously, if you have somebody that comes in with a big trauma, it's going to be obvious, but sometimes it's internal bleeding, and a lot of times you have to look for bleeding in the gut. Is the stool guaiac positive? Do you have to do an FOBT? That type of thing. Then when you look at, on the other end of the decreased production side, an aplastic anemia is always a possibility. This is a bone marrow issue. And of course can be underlying, there could be an underlying malignancy that is leading to that. And then another option here is anemia of chronic kidney disease. And how does this work? Well, when you have chronic kidney disease, often in the later stages, you'll remember the kidneys produce EPO, erythropoietin. So at later stages of kidney disease, your endogenous EPO production can decrease, so your bone marrow isn't stimulated as much because it doesn't have that EPO stimulating it. That's why a lot of people with CKD will get EPO injections monthly. And lastly, hypothyroidism. The thyroid can basically do anything it wants, if you ask me. And this is a kind of a confusing mechanism behind why it, but always check a TSH. It's worthwhile. The hemolytic anemias, you can look at this as congenital causes versus extrinsic, congenital or acquired, I should say, versus extrinsic. And for whatever reason, the boards, USMLE, COMLEX, love testing the congenital acquired things, even though they're much more rare. So we'll go over a bit of those here. The first is hereditary spherocytosis. I have a really good video on that as well. But that's a condition where basically that has to do with deficiency or malfunctioning of intracellular cytoskeleton and membrane proteins in the RBCs. Paroxysmal nocturnal hemoglobinuria, for whatever reason the boards love testing this, even though it's a very rare condition. G6PD, one of the biggest things the boards like testing. It's more common, but the most common out of all these, that's for sure. Pyruvate kinase deficiency is an enzyme in, of course, glycolysis that could lead to hemolysis. Notably with this, you'll have Burr cells, which are very unique looking, and of course sickle cell anemia. Your extrinsic hemolytic anemias, one of the biggest is autoimmune hemolytic anemias, which can be broken down into warm and cold agglutination or hemolytic anemias. The microangiopathic hemolytic anemias, also known as the MAHAs, M-A-H-A. There's many types of these. One of the most common ones that we think of is DIC, or disseminated intravascular coagulation, where you basically get microclots which cause shearing of RBCs that pass by them. HELP syndrome, which is hemolysis, elevated liver, low platelets. And then HUS, or hemolytic uremia syndrome. Those are some of the big MAHAs. And as well as infection. Infection is another one, kind of like what we said with the thyroid. Infection can do whatever it wants, including hemolytic anemia. And I've included this right now, if you recognize this. This is a prosthetic heart valve, because people with heart valves, or prosthetic heart valves, also can get hemolytic anemias just from the pure shearing of RBCs passing through the plastic hardware. And with that concludes this lecture on normocytic anemia. I hope you found this helpful.